Hello everyone, and thank you for attending today's webinar introducing 4 new measures of person-centered assessment and care planning for managed long-term services and supports plans. Before we begin, here are a few housekeeping items. At the bottom of your audience console are multiple application widgets that you can use. You can expand each widget by clicking on the Maximize icon on the top right or by dragging the bottom right corner of the widget panel. This webinar is being recorded. The recording will be available 1 day after the webcast at the same audience link. The webinar recording and slides will also be available on the MLTSS page on Medicaid.gov in September. A copy of today's slide deck and other items are available in the Resource List widget. It's a green file icon at the bottom of your screen. If you have any questions for presenters, click on the Q&A widget at the bottom and submit your question. If you would like to ask your question via phone, you can do so at the end of the presentation by dialing 5*, and we will unmute your line. We will try to answer as many questions as possible during the webcast at the end of our presentation. If we run out of time, your question will be answered later via email. We do capture all questions. If you have any technical difficulty, please click on the Help widget. It has a question mark icon and covers common technical issues. Now I'd like to pass this over to Deborah Lipson from Mathematica Policy Research, who will be leading this webinar. Deborah, you now have the floor.
Thank you very much, and a warm welcome to all the participants attending this webinar. My name is Deborah Lipson from Mathematica Policy Research, and I will be your moderator today. The new quality measures for Medicaid managed long-term services and supports programs and health plans that we will present today were developed and tested with support from CMS through a contract to Mathematica and our partner, the National Committee for Quality Assurance, NCQA. We are very grateful to the Center for Medicaid and CHIP Services at CMS for their guidance throughout the process of developing and testing these measures. I'd also like to recognize the valuable contributions of our technical expert panel members, who provided lots of advice on how to make the measures most useful, and to the many health plans that participated in testing the measures. We couldn't have reached this milestone without their time and dedication. For those of you who may have joined a little bit late, just a few quick reminders about logistics for today's webinar. All lines are muted so that we can minimize background noise, but if you'd like to make a comment or ask a question, please use the Q&A function on the webinar platform to send your message. We'll be monitoring the questions as they come in, and we'll address as many as possible during the Q&A period after the presentations are completed. If you'd like to ask your question by phone, open the content box at the bottom of your screen to find the call-in number. And again, webinar slides are available on this platform and will also be available on the MLTSS site of Medicaid.gov. Our webinar today has 2 key objectives. First, to describe in detail the 4 new quality measures related to comprehensive, person-centered assessment and care planning conducted by managed LTSS plans, hereafter called just MLTSS. Because these measures have standardized definitions and specifications, they can be used to compare the quality of care delivered by MLTSS plans within a state and across states in a consistent way. Second, we will address some of the challenges in collecting data for these measures and how to validate the measures as reported by health plans. We'll also offer some strategies for overcoming these challenges based on the lessons we learned from testing these measures with several MLTSS plans. Our agenda for today includes introducing our speakers, and after that we'll cover 4 major topics. First, we're going to provide an overview of the state MLTSS program landscape, which sets the context for the use of these quality measures. Second, we'll describe the 4 measures in detail and address some frequently asked questions. Third, we'll be presenting some strategies for collecting complete and reliable data that are needed to construct the measures according to the specifications, as well as some best practices in validating the accuracy of the measures. Last, we'll review some common challenges that health plans may face in abstracting the data to report the measures and some tips on how to overcome these challenges. We will do our best to leave the last 30 minutes of this webinar to answer your questions. First, for introductions, let me first invite Debbie Anderson, Deputy Director of the Division of Managed Care Plans in the Center for Medicaid and CHIP Services, to say a few words on CMS's behalf. Debbie?
Thank you, Deborah. Hi, everyone, and welcome to the webinar. We're really excited today to have you all here to be at a point where we are. It's been several years in the making, from the development of a technical expert panel to come up with these measure concepts, and then through testing, and now to the point where we are, where the technical specifications are published out on Medicaid.gov and available for states to use. The measures are voluntary for states to use, but we are excited for states to start adopting these measures into their managed long-term services and supports programs as a way to start getting more national measures that are comparable across states and across plans. So thank you very much for your attendance today. Please ask any questions. We are happy to walk through any responses we can, and thank you.
All right, thank you very much, Debbie. Our other speakers for the day are two from Mathematica, two from NCQA. Again, I am Deborah Lipson, a senior fellow at Mathematica, and I led a couple of the projects that produced these measures. Krista Hammonds, also at Mathematica, is a program analyst who is instrumental in measure testing. Our steadfast partners in this effort at NCQA include Aaron Giovanetti, a senior research scientist, and Dan Roman, senior research associate. It's been a real pleasure and a privilege to work with Aaron and Dan and the rest of their team at NCQA, and I'm grateful to them for their commitment in bringing these measures to fruition. To begin, I'd like to provide a very brief overview of the current state of MLTSS programs across the country, the environment in which these new measures will be used. As of July 2016, 20 states operated MLTSS programs which enrolled some or all beneficiaries who receive LTSS, either in home or community-based settings or in institutions. At that time, just over 1 million people were enrolled in MLTSS plans, with the number of LTSS users in each state ranging from under 5,000 in 3 states to over 50,000 in 5 states, including Arizona, California, Florida, New York, and Wisconsin. States typically contract with 3 to 10 MLTSS plans in each state, ranging from just 1 in Rhode Island to more than 30 in New York, for a total of about 120 health plans nationwide, many owned by the same parent company. The number of states with MLTSS programs has increased since 2016, now stands at about 24 in 2018. And as more states shift to MLTSS and gain more experience, the need to measure program outcomes and quality has increased. The new quality measures, which were carefully designed for MLTSS beneficiaries enrolled in these plans, represent a major step forward in giving CMS, states, health plans, providers, and consumers the ability to compare the performance of MLTSS programs and plans within and across states. As required by federal Medicaid rules, state Medicaid agency contracts with managed care plans must include provisions requiring the plans to conduct assessments and create care plans for all new enrollees within a specified period of time after they are enrolled, and for continuing enrollees, annual updates. MLTSS plans depend on these assessments and care plans to arrange for all needed services and supports. However, in most cases, state contracts do not specify the content of the assessment or care plan. So even if they're timely, they may not be comprehensive or person-centered, which means covering the key dimensions of beneficiary health, mental health, functional status, personal goals, and many other aspects of their life that are very important to receiving appropriate care. The lack of consistent standards for judging whether assessments and care plans are comprehensive and person-centered led CMS to ask Mathematica and NCQA to systematically identify the core components of assessments and care plans that are deemed to be high quality. Specifically, CMS wanted to create nationally standardized measures for use across MLTSS plans and state Medicaid programs in order to fill key gaps in MLTSS measure domains. In addition, CMS wanted to ensure that these measures met scientific standards for validity and reliability through rigorous testing. The measures we will present today focus on person-centered assessment and care planning, but we all recognize that there's many other types of measures that must be included in a suite of MLTSS performance measures, including those that measure progress in reducing unnecessary use of institutional care, improving quality of life, increasing beneficiary choice and control. There are other measures that have already been developed or are currently being developed for some of these outcomes, so we made a point not to duplicate any of these efforts. And some of these measures are derived from the HCBS Consumer Assessment of Healthcare Providers and Systems, or CAHPS surveys, as well as from the National Core Indicator surveys. And obviously, we're not going to be discussing those here today. The 4 comprehensive assessment and care planning measures that we will present today represent critical processes that lead to the outcomes that I think we all agree are important to beneficiaries and their families, to health plans and LTSS providers, to state Medicaid agencies, and to CMS. In addition, we feel that we need to measure these important processes in order to ensure that we're tracking whether, in fact, these processes lead to the important outcomes, including reduction of risks and adverse health outcomes, reduction of unnecessary institutional stays, and improved quality of life. The 4 assessment and care planning measures briefly are listed here. We'll go into great depth in the rest of this webinar, but very briefly I wanted to show them on this slide. They include first the initial assessment as well as annual updates, the initial comprehensive care plan and annual updates. The third is a care plan that is shared between or with primary care practitioners to promote coordination between the individual's medical and long-term services and supports providers. And then the 4th, reassessment and care plan updates after discharge from hospitals or other inpatient facilities, since these events frequently result in changes to an individual's needs. In addition to making these measures publicly available on CMS's Medicaid.gov website, NCQA's governing board recently voted to adopt these 4 measures for inclusion in 2019 HEDIS specifications for LTSS. NCQA assigned acronyms to these new HEDIS measures, as they do for all HEDIS measures shown on this slide. You'll see them here, CAU, CPU, SCP, and RAC. Clearly, we don't expect you to memorize these acronyms, so we'll be using their full names in the remainder of the webinar. But just so you know, they are aligned, all the same. What you see on the Medicaid.gov website is the same as what you'll see in the HEDIS specifications. Noting that, of course, when health plans calculate and report these measures to NCQA, they must be verified by a certified NCQA auditor. So with that set of background and introductions, let's take a deeper dive into the 4 measures with Erin Giovanetti from NCQA. Erin?
Thank you, Deborah. So, hi everybody, I'm Erin Giovanetti. I'm with the National Committee for Quality Assurance, and I'm delighted to walk you through in more detail these 4 measures. So the first measure is LTSS Comprehensive Assessment and Update. So this measure is looking for the percentage of MLTSS plan members who have documentation of an in-home comprehensive assessment covering core elements. And we'd like to see that assessment done within 90 days of enrollment or annually if the member is an established member. So this measure actually has 2 rates to it. The first rate looks for the documentation of the 9 core elements, which are listed on the slide. And these are considered kind of the floor of what we consider to be the minimum set of elements that should be included in any comprehensive assessment for LTSS beneficiaries. The second rate is a bit of an aspirational rate. it looks for the documentation of the 9 core elements, plus at least 12 supplemental elements, which are laid out in the specifications in greater detail. And these include things like instrumental activities of daily living, assessment for social arrangements and social functioning, and other areas that we think are still important for the LTSS population, but we wanted to also provide flexibility for organizations that may have differences among their assessments. So you can see the 9 core elements that are listed here. These include that we expect to see in order to achieve the first rate. And these 9 core elements include activities of daily living, an assessment of cognitive function, an assessment of living arrangement, documentation of current medications, assessment of mental health status, the availability of friend or family caregiver support, a list of acute and chronic conditions, a home safety risk assessment, and documentation of current providers. So some commonly asked questions about this measure. Does the assessment have to take place in the home? Based off the input of our experts as well as research that we did in the development of these measures, we strongly believe that in-home assessment for members in managed LTSS plans is critical. So we do look to see that a face-to-face discussion is done in the member's home, unless certain exceptions are met. And those exceptions include whether or not an individual refuses an in-home assessment or says that they would prefer to have an assessment done by phone. If an individual is residing in a post-acute care or other facility at the time of the assessment, so for example, if someone is residing in an institutional facility in the first 90 days of enrollment, the assessment can be done in that facility. And then we're also aware that some states include a large population in what they define as their MLTSS population, and they don't require in-home assessment for that entire population. So if there is a state regulation that excludes the member from requirement for an in-home assessment, they can also be excluded from the requirement for in-home assessment from this measure. There are 2 exclusions in the measure. These are exclusions which are reported with the measure rate, so they provide context about the measure rate. So the first exclusion is for members who refuse an assessment. There must be documentation that the member refused the assessment, in which case that will be counted as an exclusion, and the rate of individuals in the population who refuse assessment should be reported with the overall measure rate. There's also an exclusion for members who could not be reached. In order to use this exclusion, there must be documentation of at least 3 attempts were made to reach the member and that they could not be reached. Similar to the other exclusion, this exclusion is reported with the overall measure rate. So when you're looking at a measure rate, you can see if they have, for example, a measure rate on the overall measure that says 90%, but they also show 50% of the population could not be reached. That's a good context piece to put in combination with that 90% rate, because you know that is only reflecting the 50% of the population that could be reached. The next measure is LTSS Comprehensive Care Plan and Update. This measure looks at the percentage of LTSS members I forgot to move the slide. The percentage of MLTSS members who have documentation of a comprehensive LTSS care plan. Once again, we're looking for documentation of 9 core elements. And here we're looking to see that documentation within 120 days of enrollment or annually. So this time frame is set up for you to have an assessment within 90 days and then a care plan to be documented within 30 days of that assessment, or 120 days total. Similar to that assessment measure, we have 2 rates in this measure. The first is the rate looking at the 9 core elements, which we consider to be the minimum requirement for a LTSS comprehensive care plan. And the second rate looks for 9 core elements plus at least 4 supplemental elements. And there is a list of supplemental elements in the measure specification. The 9 core elements include at least 1 beneficiary-defined goal, I'm sorry, I'm seeing that there is some difficulty hearing me, and so I apologize. Deborah, is that any better?
Just slightly, yes. Thank you.
Okay, I will try to hold that right up next to my face. So we're looking for documentation of a beneficiary goal, documentation of a plan for meeting medical needs, a plan for meeting functional needs, a plan for cognitive needs, a list of all LTSS services that are being rendered or will expected to be rendered, a follow-up and communication plan with the care manager or whoever is developing the plan with the member, an emergency need plan, so a plan for what may happen in case of an emergency, documentation of whether caregivers were involved in the development of the care plan, and then finally, member agreement to the plan. So there must be documentation that the member agreed to the plan, or if the member did not agree, that the plan is in the appeals process. Some commonly asked questions. Does the completion of the comprehensive care plan have to take place in the home? No. For this measure, we do not require in-home completion of the care plan, but it must be done face-to-face unless certain exceptions are met. And those exceptions are the same as the assessment measure. So if the member refuses to have an face-to-face conversation about the care plan or requests a telephone conversation instead, that's allowable. Also, if the member is residing in an institutional facility at the time of care plan development. And then finally, if there is a state regulation that allows an exception for face-to-face development of the care plan, that is an allowable exception. Another question that we often hear is, what if there's documentation of no change in status? So this could be that this is an update. Documentation of no change in the care plan is not sufficient. We are looking to see what the current care plan is, so this must include documentation of what the care plan is at that moment. So what, for each one of those elements, what is the current status at this moment? What if there are multiple care plans documented during the measurement period? The measure directs you to use the most recently updated care plan. What if the member refuses a care plan? So similar to the assessment measure, there must be documentation of that refusal, and this rate of refusal is reported as a rate that goes along with the overall measure rate. And finally, what if the member could not be reached? Similar to the assessment measure, there must be documentation that at least 3 attempts were made to reach the member and that they could not be reached. And then they can be excluded from the denominator of the comprehensive care plan measure. However, this rate of could not be reached should be reported along with the overall measure rate as a piece of context. This third measure builds on the care plan measure and looks to see the percentage of MLTSS plan members with a care plan that was transmitted to their primary care practitioner or other documented medical care practitioner identified by the plan member within 30 days of its development. So here we're really looking for some type of coordination between LTSS care and the medical care provider. And we want to see in this measure documentation of who the care plan was submitted to, the date of transmittal, and a copy of the transmitted care plan or plan sections. The entire care plan does not need to be transmitted, only the relevant parts, and providers may determine what those relevant parts are, but there needs to be documentation of what was shared. Some frequently asked questions about this measure. So first, does the care plan need to meet the criteria of a comprehensive care plan outlined in the LTSS Comprehensive Care Plan and Update measure? So that was the previous measure I discussed. So yes, this measure is designed to say from everyone who has documentation of an LTSS Comprehensive Care Plan as specified in the previous measure I looked at, essentially that becomes the denominator for this measure. And so that's the population from which you would look to see, of those people with an LTSS comprehensive care plan, how frequently was that shared with a primary care provider. Next question we often get is, why is the care plan shared with just the primary care practitioner? Well, we're really looking to promote coordination of medical and LTSS services, and often the PCP is the coordinator of all medical services. However, we do recognize that for some individuals, they may have a provider who is acting as their main point of contact for all medical care who is not a primary care practitioner. And so it is allowable in this measure that if the member identifies a provider as their main medical point of contact, the care plan can be shared with that provider. How does sharing LTSS care plans and with PCPs promote coordinated care? Even if MLTSS plans do not provide or cover primary care for the member, sharing the LTSS care plan with the PCP makes it possible to coordinate those LTSS and medical services. So really the point is that the cornerstone of any coordination is sharing of information that needs to happen first, and so that's what this measure is looking for. The next measure is LTSS reassessment and care plan update after inpatient discharge. This measure looks at the percentage of inpatient discharges on MLTSS plan members, resulting in updates to the assessment and care plan within 30 days of discharge. So this measure essentially looks for the first two measures we looked at, care plan, but specifically looking for whether or not that assessment and care plan was updated after someone is just discharged from an inpatient facility. So the first measure looks for reassessment after inpatient discharge, and then the second rate looks for both reassessment and care plan update after inpatient discharge. And similar to the first two measures, we're looking for documentation of at least 9 core elements in the comprehensive assessment and 9 core elements in the comprehensive care plan. Some common questions about this measure. So first, this measure excludes planned hospital admissions. So we have directions for identifying hospitalizations that could be potentially planned, and they're excluded from the denominator of this measure. This measure does use administrative claims codes to identify discharges and then to also identify whether a discharge was potentially planned. And so the coding systems that are included in the value set for this measure include ICD codes, CPT, HCPCS, and UV revenue codes. As I stated earlier, the reassessment does need to meet certain criteria. It needs to include the 9 specified core elements, and it needs to be done face-to-face unless certain exceptions are met. This reassessment does not necessarily need to be done in the home. It can be done perhaps on the day of discharge in the facility. The care plan update also has to meet certain criteria. It has to include 9 specified core elements and also be done face-to-face unless certain exceptions are met. And those exceptions for the being allowed to not have it be done face-to-face include the member refusing face-to-face or requesting a telephone call. What if the MLTS member does not receive medical benefits through the MLTSS plan? So this measure is specifically designed for members in MLTSS plans who are receiving both a medical and LTSS benefit. In order to identify the denominator for this measure, you need the ability to identify inpatient discharges from administrative claims data. So if your health plan does not cover a medical benefit for the individual and does not have the administrative claims for an inpatient discharge, then those members are not included in the denominator for this measure. So with that, I'm going to pass this over to my colleague, Dan Roman, and I'm happy to answer any questions on these measure specifications when we get to Q&A.
Thanks, Erin. This is Dan. I'm going to be discussing the data collection and approaches to validation for the measures. So first, the method of data collection for these measures requires collecting a systematic randomized sample of the eligible population defined by the measure specifications. Members are identified using enrollment data, and for the reassessment and care plan update after discharge measure, administrative claims as well, since the denominator of that measure is focused on plan members who are discharged from the inpatient setting. The data for all 4 measures will come from case management records rather than medical records from provider's office. So we're talking about records that might come from a managed care plan data system or from a delegated agency system in cases where an LTSS plan contracts out assessment and care planning services. The sample size for these measures should be 411. The sample size for these measures should be 411 members that meet the eligibility criteria, which for the assessment and update, care plan and update, and care plan sharing measures is going to be members 18 and older who meet the continuous enrollment criteria. And I'll discuss that latter piece in just a minute. But for all 3 of these measures, the same sample can be used. For the reassessment and care plan update after discharge measure, we're looking for a sample of discharges for members who are 18 and older and meet the continuous enrollment criteria. Oversampling may be necessary in case substitution of eligible members is needed. And in cases where plans find that they do not have enough eligible members to get a sample of 411, they should report on all eligible members, but in cases where there are fewer than 30 eligible members identified for the denominators of these measures, plans or states may choose not to report since they will likely not have a valid, meaningful rate due to small numbers. As far as the time frame for these measures, all 4 are collected on a calendar year basis. These measures have been specified for a new volume of HEDIS for 2019, as Deborah mentioned earlier, and that means that the measurement year will be 2018. We do not recommend reporting these measures for any year prior to 2018 since the measures were not yet developed. And so I mentioned continuous enrollment earlier. This is the time frame for which a member must be continuously enrolled in the plan to be included in the denominator of these measures. For the assessment and update, care plan and update, and care plan sharing measures, the continuous enrollment is 150 days between August 1st of the year prior to the measurement year and the December 31st of the measurement year. We recognize that people move around sometimes, so for any individuals who have multiple distinct continuous enrollments during the measurement year, plans should look for an assessment to be completed in the last continuous enrollment period of 150 days or greater that occurs during that measurement year. And for the reassessment and care plan update after discharge measure, the continuous enrollment period is going to be the date of discharge through 30 days post-discharge. And just finally, with regard to validating the data for these measures, when they're reported to states, the states should conduct their own independent review of a sample of the members included in the reported results. This could be done by an external quality review organization or a state-employed abstractor. So, for example, a state may contract with a nurse who does not work with a plan to perform an audit, who does not work for the plan, who would perform an audit of a sample of the members included in the measure to reproduce the results that are reported by the plan. Where available, states may also use the audited results that will come from HEDIS when they're available. Just a note that for the first year these measures are in HEDIS, we are not planning to audit the results as we want to give the plans and states time to adjust to this new data collection. HEDIS auditing for the LTSS measures will start in measurement year 2019 for the results that are reported in 2020. So now I will turn things over to Krista Hammonds.
Thank you, Dan. Hello, everyone. My name is Krista Hammonds from Mathematica Policy Research. Now we will move into the last section of this webinar, where we discuss some potential common challenges related to the reporting and collection of data elements to support these MLTSS measures. We will also discuss some potential strategies for addressing and overcoming these challenges. So based on our field testing experience, where we worked with a group of health plans to test and evaluate these measures, we found that although the majority of health plans document the data elements required for these measures, the information can be recorded in different locations in the health plan's data management systems. For example, we found that data elements could be located in different types of assessment forms based on the individual enrollee. Furthermore, we found for national health plans that operate across multiple states, it could be common for the information required for these measures to be stored in slightly different locations within a plan system across those states. Also, for health plans that contract with case management agencies or providers to conduct assessments and care coordination, where the different data systems are not necessarily integrated with one another, information could be located in records or systems that are not immediately accessible to the health plan. An extreme example of this is when case management information could be located in physically disparate geographic locations, which would require travel and resources to locate. This is something we came across in our testing, although we did find this to be a pretty rare occurrence. So in our experience, we found that a helpful strategy for locating and efficiently collecting data is a comprehensive mapping system. Working with IT staff, health plan managers could determine which data elements are stored in each system and map the elements that they have to standard terminology. An item to note is that there have been recent efforts by the Office of the National Coordinator to facilitate the development of standard terminology. The Electronic LTSS Initiative is an ONC-CMS partnership that focuses on identifying and harmonizing electronic standards that can enable the creation, the exchange, and the reuse of interoperable service plans for use by healthcare and community-based LTSS providers, payers, and the individuals they serve. As part of the project, ELTSS standard elements were developed and field tested. Now I believe the Georgia Department of Community Health and Georgia Tech are working with ONC to facilitate and operationalize these elements into standard language. So moving on to the next potential challenge related to the reporting and collection of data elements to support these measures is the concept of negative documentation. Negative documentation refers to when an enrollee had a certain medical assessment completed and nothing was found or identified either as a problem or something to note. Based on our field testing experience, it can be difficult to find documentation in enrollee records that note an enrollee was assessed for, as an example, a chronic health condition, but none was identified. We found that providers sometimes do not document data elements unless there is something to note as a problem or something that needs to be addressed.
Krista, this is Deborah. Real quickly, can you just slow down a bit? This is really important, and I think we want to make sure everybody can follow you, okay?
Of course, sure.
Yeah.
So this can make it challenging for data abstractors to know if, when they do not see something recorded in an enrollee's record, whether this is because the enrollee doesn't have a problem or if this is because the data element was not assessed. In our experience, we found that training can be one of the best ways to mitigate this potential challenge. MLTSS plan managers could provide training on proper documentation practices for both healthcare coordinators and delegated agency staff. Furthermore, states and MLTSS plans could consider whether standard forms, protocols, or data entry options could be updated to more easily account for negative findings. Moving on to the next potential challenge related to the reporting and collection of data elements to support these MLTSS measures. We'll turn to now time and effort for multiple chart abstracted measures. For those of you who've had the experience working with HEDIS measures, you will know that when working with a chart abstracted measure, there's a level of effort that goes into abstracting the required information, the required elements to report the measure. Compounding this is when the data required for the measure is located in multiple places and not always in electronic form. One thing I would like to remind you of is that the same systematic sample may be used to calculate three of the measures we presented today: the LTSS Comprehensive Assessment and Update Measure, the LTSS Comprehensive Care Plan and Update Measure, as well as the LTSS Shared Care Plan with Primary Care Practitioner Measure. This may help to streamline the abstraction process as much as possible. Regarding mitigation strategies, in our experience, we found that there could be a role for agencies and states to play in helping mitigate the time and effort required in data abstraction of measures, where states can incentivize MLTSS plans to modernize their data systems. There is an example of this occurring at the federal level in the Adult Corset program. This 2-year grant program was designed to support state Medicaid agencies to modernize their data systems and to help in developing staff capacity to collect, to report, and to analyze data on the core set of healthcare quality measures for adults enrolled in Medicaid. A similar incentive system on the state level could help in the modernization of plans' data management systems. MLTSS plans operating in multiple states, for example, could begin mapping and transitioning data elements from comment fields into standard elements to optimize their data systems. Now moving on to our last potential challenge related to the reporting and collection of data elements to support these MLTSS measures, data reliability. Obviously, for abstracted measures like these, health plans are relying on the person abstracting the information and trusting them to abstract measures in a consistent way. In our experience, we have found that data elements may be abstracted inconsistently from members' records. Something that we encountered during our testing is that elements that were not in a structured field were more prone to abstraction errors. Therefore, we would encourage MLTSS plans to begin mapping and transitioning data elements from comment fields into standard elements. Lastly, MLTSS plan managers, could train record abstractors on what these elements mean and how to interpret documentation they see in assessments, in care plans, in a consistent way. I will now turn the presentation back to Deborah to discuss where you can find additional resources and support on these measures.
Thank you very much, Krista. We mentioned at the beginning, we want to emphasize again that the detailed technical specifications for these 4 measures and additional information about MLTSS more generally can be found on this website at Medicaid.gov. You'll see them listed under, I believe it's just called Technical Specifications. And it's a fairly long document. It's about 80 pages because it really has all of the information that we just described to you in probably a little too quick fashion, but you can read it at your leisure and really study it and try and figure out what it means for you at the state level or in health plans. And if you have any questions, do not hesitate to send us a question at the email address that you see on your screen here. One other thing I'd like to note is that those technical specifications on Medicaid.gov also include the technical specifications for 4 additional measures that address domains and quality issues besides assessment and care plan. I believe we had a question from the audience about those other measures. You may have heard about them before, but those technical specifications are now available in the same document for these 4 other measures, including falls risk reduction, minimizing institutional care, measuring the admissions to institutions as a way to look at rebalancing, and then successful discharge from institutions back to the community. We hope to cover some of the information and details about these other measures in a future webinar. We don't have the time today to do that, but we encourage you to take a look at those specifications for all 8 measures, and if you have questions, please, again, submit your questions to this email address. With that, I believe we have a lot of time to answer your questions. We've already had a few come in, but let me encourage you now to think about what you've heard on the phone today from all of our presenters. Submit your question using the function, the Q&A function, or if you'd like to ask your question by phone, once again, you can open up the content box at the bottom of your screen to find the call-in number. You can you can raise your hand, so to speak, by unmuting your phone with the star 5. Bryce, did we get that correct? Is it star 5 or 5 star?
So that's 5 star to raise your hand in the interface, and then we can unmute you.
Great. Okay, thank you. Please, we have a lot of time here to address your questions. Let me turn to my colleague, let's see, Jessica Ross, who's been monitoring the questions. Let's see. Jessica, can you unmute your line and indicate which of the questions that we've received? Let's see, questions folder. All right, I'm just going to take one of the first ones here. The question came in from one of the health plans. Some plans share a copy of the comprehensive care plan with the member and the PCP. Will consideration also be given to the care plan sent to members as well? I'm going to offer a response, but would welcome anyone else of my colleagues to answer. I think that is terrific. I think that is important. In fact, we assume that health plans will get the consent and signing of the member to the care plan, so we kind of assume that the member is involved in signing off on that care plan, but for the purposes of the third measure, the shared care plan with a PCP, sharing it with the member would not necessarily count. Erin, do you have anything else to add?
No, I think you said that perfectly. I think that's what we encourage that, absolutely, but this measure is looking for sharing with the PCP.
Great, okay. A related question on that particular measure, the shared care plan, what parts of the shared care plan would be appropriate for transmittal to the PCP? All of it? Parts of it? Erin or Dan?
Yeah, I think that's an excellent question, and part of the reason why we didn't want to specify that is it may be based off of an individual basis and what is most critical in an individual's care plan. For example, if an individual doesn't have any cognitive needs and the plan for cognitive needs is documentation that they have no cognitive needs, then I don't think you really need to be sending that. So some of it may be based off of where there is clearly a plan for helping the patient. It may also be based off of relationships that you have already with primary care providers. So we found in research that the best way to coordinate is to actually understand what's the information that primary care providers would value seeing. And so understanding those relationships and trying to strengthen those relationships so that the information that's sent is really what is most valuable to primary care providers is what we recommend, but we don't want to be prescriptive about what that is because it may vary by individual and by primary care provider.
Great. Okay. We have a question from a state official, a state representative. If states are planning on using these measures, how far in advance do states need to reach out to the MCOs that do cover LTSS before the date that MCOs will need to begin reporting? That is a really good question. That, how you roll out these measures in a way that gives the MCOs a chance to really tune up their data systems and be prepared to report the measures is really critical. More time the better, clearly. I'm not sure there is a, specific time, but I don't know. Erin, do you have any opinion on that?
Yeah. So, my guidance is really based off of the way that we structure HEDIS reporting. So you clearly want to give people, you can't have, you want to give people notification that the measures were voted. You can, the way that we've done this for HEDIS is that the measure specifications will be published in 2018 for optional reporting in 2019 that will not be publicly reported. So basically, because the measure specifications are being published midway through the measurement year, we don't want to hold plans accountable for a measurement year in which they didn't have the measure specifications, but there's still valuable experience that can be gained from that first year of just seeing where people are as a baseline metric. So the measure specifications are going to be published in September, and we're going to ask for reporting on measurement year 2018 in June of 2019, with the hope that in future, that by 2020, we would have actual reporting that could be publicly reported based off of measurement year 2019, because plans will have had a full measurement year with the specifications to understand how they're doing.
Right. Yeah. The whole point is that you can't. This is not a turn on a dime kind of a process. I think both states and MLTSS plans need to really think through the timeline, how they're going to, in a sense, pilot test, begin to develop a plan for submitting these measures, validating them, reporting them, giving feedback to plans. So it is a long process, and I don't think it would be realistic for any state to, say, well, we're going to start collecting these measures and reporting on performance and comparing you on a public website, for a while, until you really begin to see what the results are and make sure that they are accurate and reliable. We have a question from another state Medicaid agency that it's somewhat related here. The question is, given how specific these measures are, and MLTSS monitoring and oversight more generally, what kind of staff might be needed to monitor MLTSS performance on these measures, distinct from monitoring Medicaid managed care more generally? I think this speaks to the state capacity to really understand what these measures are, and when you look across plans, if you see huge variation, is that truly because of quality? Is it because of variation in MLTSS plans' data systems, their capacity to abstract the information correctly, and then again, how you actually use these measures for state oversight purposes. It's hard to give, a clear or one specific response to that question, other than to say MLTSS monitoring and oversight generally should be done in conjunction with Medicaid managed care contract staff, but that the quality measurement really does require people who are versed both in quality measures and in LTSS. Whether state Medicaid agencies always have the one person who can do both things, that may not be the case. So it's probably, for some smaller states, an issue of trying to bring together the expertise from various places within the state Medicaid agency or from other departments. For example, if there are staff within the Department of Public Health who are much more familiar with quality measurement, bringing them to work with state Medicaid agencies, or if there is other staff within the Department of Aging and Disability who understand LTSS in greater depth than perhaps Medicaid managed care oversight staff, those kinds of folks would be an important part of the team. Krista, Dan, Aaron, any other comments, advice for states with staff who may not have all of that expertise in one person?
I think you summed it up nicely, Deborah.
All right, good. All right, Let's see. Bryce, I just want to make sure, is there anybody waiting on the phone to ask a question?
No one on the phone has raised their hand at this point, but just a reminder for folks who have called in, please press 5* on your keypad to raise your hand and be unmuted.
Right. Okay. I think we answered another question earlier, but I just want to make sure folks heard it. The question came in regarding the additional MLTSS measures that I mentioned before, the falls risk prevention, admission to an institution from the community, successful discharge after short-term institutional stays, and successful transition after long-term stays. We have completed the measure testing, and we have found that they are valid and reliable. We changed the names of some of these measures, which you'll see in the MLTSS technical specifications document that that I think actually is available as a resource to webinar participants now, and is available on Medicaid.gov. There is not necessarily any more time for public comment on those measures since they have gone through the complete measure testing cycle. However, we have submitted those measures to the National Quality Forum for consideration for potential endorsement, and NQF does offer an opportunity for the public, for all of those of you on the phone, to actually comment on that. So that will be something in the fall that you can look for if you're interested in commenting further on those measures. All right, let's see. All right. I'm going to go to another state question, question from one of the states. For states that include HCBS waiver services in the MLTSS capitated rate, how would you recommend aligning assessment and care planning activities with CMS requirements for HCBS waivers? Well, we think they're already pretty aligned and consistent. Let me see. My notes indicate that whether you're looking at the Medicaid managed care rules, I think it's 438.208. Debbie, you can correct me if I'm wrong, as well as all of the 1915 waiver authorities that cover HCBS. Those assessment and care planning requirements are in there. The federal rules require that the contract with managed care plans include assessment and care planning. But as I noted before, those federal rules, whether it's for managed care, MLTSS, or for HCBS waiver services, only specifies that an assessment and care planning must be done within a certain time period. They do not specify the content. So again, these are kind of separate streams of work for a state Medicaid agency to think about. On the one hand, you want to make sure your state contracts with the plans require them to conduct these assessments and care plans within a certain period of time for new enrollees and on the annual update schedule. But if you're thinking more about the quality of those assessments and how comprehensive they are, and how person-centered those care plans are, those are more the quality measure side of the equation. And, those might be, if you include quality measure specifications and reporting schedules in your contract, great. Or if you conduct that through a separate process, that would also be acceptable. I may not be getting that absolutely right, so the Minnesota person who asked that question, if I didn't answer it quite right, please submit another question. And let me just see if Erin, Dan, or Krista have any other suggestions for aligning these measures with the CMS requirements for HCBS waiver programs.
it's kind of hard for me to say based off of how, not understanding exactly the situation that the state is in. I will say that we specifically for the HEDIS measures, they're actually designed to be reported by either an MLTSS plan or an organization that is organizing and providing LTSS, which could include organizations that are contracted with a state or managed care plan to provide HCBS services. So these include area agencies on aging or other community-based organizations. And our intent by having the measures be the HEDIS measures be specified for both levels was exactly that point of we want there to be complete alignment between the assessment and care planning activities and the way that the organizations are evaluated. So for example, if a community-based organization, an area agency on aging, is contracting with a health plan to do the assessment and care planning, they're going to be held to the same standards as the health plan in terms of what we're looking for in the assessment and care plan measures.
Okay. We've got another question regarding, in a similar vein here, about state regulations. We, in the specifications that Aaron mentioned for the first two measures, that's comprehensive assessment and comprehensive care plan, we say that there is an exception for the either in-home or face-to-face requirement if state regulations do not require such face-to-face or in-home assessments and care plans. One of the questioners said, well, it may not be actually in a state regulation. It may live in some sort of sub-regulatory guidance. So I guess the question is, how strict is that, quote, state regulation term? I personally think that as long as there's something in writing that, wherever it is, even if it's not a formal rule or regulation at the state level, it may be in guidance to the plans or something else that would be sufficient to qualify for the exception. Aaron, any thoughts or further comments on that?
Yeah, so I think that's an excellent point, and that might have been not clear enough language on our part that we can certainly work on in the next update. So exactly that. It's basically sub-regulatory guidance would definitely count as well if it's not an actual state regulation. Any documentation that there is a state exception for face-to-face discussion or in-home assessment would count.
Yep, good. Okay. We have a question that's been waiting for a while patiently. Thank you for your patience here, but I'm going to ask the person who asked the question to just clarify something. It said something about UTR members. I'm not sure what that means. Is that only by phone, or is there an expectation to try to see the member at the address provided? And I don't know what UTR means. I'm trying to I don't know. Does that ring a bell for Dan, Krista, or Aaron? UTR member?
Possibly unable to reach. So the measure does not specify differentiating whether or not the 3 attempts were made by phone or in person. So there is no expectation that if you could not reach the member by phone to schedule an assessment that you also try at the member's house. That's not laid out in the specification. So it's so that's what the measure is specifically looking for. However, in practice, we do recommend, clearly because assessment is the cornerstone of being able to provide services, we do recommend that plans try every means possible to track down these members and to try to conduct an assessment with them. And we'd also note that, if they're not making very sufficient efforts to track down people, then that reported rate of people they could not be reached is going to be high, which, while not, a quality measure, does put in context their rate of assessment.
Right. Good. Okay, there is a follow-up question to one of the previous ones. Again, this is a state Medicaid agency official trying to understand exactly how they're going to use and roll out these measures in a judicious way. It has to do with the timing, when states should expect or could expect plans to start reporting these measures. It intersects with the whole issue of a reporting year. So the question is, should states ask the plans to report starting in 2018, or now that these measures are available, or should we have it moving forward to the beginning of 2019 because it's not clear the plans will be able to report these data in 2018? So Erin or Dan, it's sort of the reporting year, the start of the reporting.
Yes, we would strongly recommend, if you can, to have states report these measures on the year 2018. So because they need a full year of data to look at it, that means the reporting would be in the year 2019, but it would be on the year 2018. We recommend that to give states or plans experience with calculating these measures and reporting these measures. This also helps then to eventually have these measures be publicly reported. So for example, if you decide to have states, your plans in your state report on these measures through HEDIS, we need to have at least 1 year of data reported to us on a sufficient number of plans before we can publicly report benchmark data for health plans. So if we can get a sufficient plans reporting in 2019, in June of 2019, on the measurement year 2018, then that will allow us to conduct our, to view the data, analyze the data, and make sure it's suitable for public reporting. And that public reporting would then happen in 2020. So that's my recommendation. I will say it's from a selfish point of view of really wanting to get these measures to a point of being able to be publicly reported. But we don't recommend necessarily holding plans accountable in terms of tying payment or incentives or publicly reporting those results that are based off of measurement year 2018, simply because plans haven't been able to see these specifications until now.
Great. Thank you, Erin. We have a question from a plan in New York, I believe it is, asking whether would these measures apply to manage long-term care plans in that state. And for the rest of you who may not be from New York, those plans only cover LTSS. They do not cover any acute, primary, or specialty care services unless they happen to have an aligned DSNP program or participating in the dual demonstration program. But this would be a similar kind of issue that might come up in not only New York for MLTC plans there, but also for Florida plans that only cover LTSS, not any medical acute primary or specialty services, as well as Wisconsin's family care program, I believe. But yes, the idea is that absolutely these measures should apply to MLTC plans, particularly but it would the only measure that would not apply to such plans, as Erin described before, is the fourth one, the reassessment after an inpatient discharge, if the MLTC plan really don't have any access to information about whether your member has been admitted to or discharged from the hospital or another inpatient facility. I mean, one could argue about whether you should be tracking your members' use of these services, but I believe we've made an exception for plans on the fourth measure, the reassessment after inpatient discharge, if your plan does not cover these acute medical services. Erin, would you agree?
Yeah, I would agree. I mean, I think the real issue there is about the data availability to be able to identify your entire denominator. We certainly encourage you to be tracking these things, but you would not have the administrative claims data to be able to track the denominator of people that are discharged that would meet the standards of this measure. So that's why those plans that do not cover a medical benefit are excluded from that measure.
Right. Okay. Okay, yeah, I think there was another question very similar to that for partial capitated plans, which in this case means only covering the LTSS benefits that don't cover inpatient, but do have the services that relate to transitions of care. The question is, should this not be included as a partial element of the, again, I think that's the same question, but slightly differently stated. So I think we can mark that one as checked unless somehow that didn't answer your question. All right, let's turn to a different area. This is an interesting question. So when we talk about caregiver involvement in the comprehensive care plan and update measure, what about members who don't want their caregivers involved? I think we have an exception for that. Yeah. Go ahead.
The measure actually says documentation of whether a caregiver was involved in the development. So if there's no caregiver involved, then that's fine. You can just document that no caregiver was involved, and that meets the requirements for that element. This is really to be trying to bring attention to the fact that we think caregivers are important to include in the care planning process, but we also recognize there are many situations where it may not be appropriate to engage the caregiver if the patient refuses, for example, to have the caregiver be involved. So really what we're just looking for documentation of is if a caregiver was involved, yes or no. And so documentation that a caregiver was not involved is sufficient.
Okay. A related question that sort of gets to the whole notion of is this whole process truly person-centered? I think one of the participants was looking at the core elements of the care plan, and that looked at one of the 9 core elements had to do with beneficiary goals for their own care and member agreement to the plan. But I guess this is more of somewhat of a philosophical question, if you will. But how else are these measures really showing that the plan is person-centered? So, go ahead. Yeah,
Deborah, I think this gets to some of your earlier point about these are not measures that are the only measures we would recommend using for MLTSS plans, and that's where there are patient-reported outcome measures, such as the CAPS measures that look at experience of care with HCPS, or other measures that are in development, or we know also of the national indicators that can provide a lot of information about, from a patient-reported perspective, of whether or not the care they're actually meeting their needs. That's clearly not something we can get at measures that are solely on records. That survey or some type of patient-reported measure, which was not the intent, which was not what we were developing in this project. All that being said, though, I think that where we do see these measures as being person-centered is that we do think that by looking at all of these different elements, you are getting a complete picture of the person. And that's kind of where we wanted to go with, is that it's really comprehensive of all these different elements that could be impacting a person's life, and wanting to have a true comprehensive assessment, a comprehensive care plan that's addressing all these different elements. But we do agree these measures need to be used in combination with some type of person-reported outcome measure that gets at what individuals are saying about the care they're receiving.
Right. There's a related question that has to do with something that Krista mentioned earlier about the, quote, negative documentation, something that isn't obvious, and you really have to make sure that the health plan records somehow specifically address it. It's one of these things that can be difficult. But what about barriers to beneficiary goals, achieving their own goals? I mean, is there any strategy for saying, there are some issues, we're still working on them. We don't actually use any measures that say, did you achieve those goals? That's also what Erin was talking about, where you get at that with other kinds of measures through the HCBS CAP survey or National Core Indicator surveys. But any other thoughts, either Krista, Erin, Dan, on how to, again, really making sure that we maximize the use of these measures to see that assessments and care plans are truly person-centered?
I think it's an excellent question, and I go back to that these measures are a starting point, and they need to be accompanied by additional, looking at things such as the structures that plans have in place to understand, do they have people with care managers with motivational interview training or things like that can help to really make these care plans as person-centered and as beneficial as possible. I think where we struggle with some of these quality measures is we are limited by what can be validly and reliably measured through what is documented in the record. And that's where we need to have, and sometimes it feels a little insufficient because we are trying to set one standard across every plan that can be evaluated by reviewers that are reviewing these records. And so that's where I would come back to, by just saying there needs to be documentation of barriers in a plan, that actually brings us a lot further than a lot of care plans that I've seen, and that they need to be coupled with measures that get at patient report of whether or not they are achieving their goals and whether their priorities are being respected.
Yeah. All right, great. Thanks, Erin. It's a tough one, but I think it's something we need to all think about some more. Here's a couple of other little bit more technical questions about the measure specifications. This goes back to the shared care plan with the PCP measure. Would we need to get a release of information from the member if we don't have access to that information for MLTSS members? In other words, if a plan, this goes back to the same issue with the New York, Florida, Wisconsin plans that only cover LTSS and not acute care. If they're not in touch with it, their provider networks don't include primary care physicians, they don't have any relationship with those primary care physicians, would the plan need to get a release of information from the member to share that plan with the PCP?
So there is no need for a release of information. If a member gives you the name of their PCP, you are allowed to share information with that PCP if the member gives their permission. There is an exclusion in this measure for members who refuse to have their care plan shared with the PCP. So if your member refuses, then they are excluded. If we're expecting that plans or anybody that's providing LTSS should be trying to coordinate those LTSS services with medical services, even if they don't provide that direct medical service. And so if that has to be done through working with the provider to identify who their PCP is and then trying to contact the PCP through the information provided through the member, that's what we would recommend if you don't have access to any other records. But we are looking to see that there was effort to try to connect with the medical care provider.
A related question, will sharing the care plan with the PCP on a provider portal fulfill the transmittal requirement?
Yes. It will. It is in the specification that is acceptable.
Okay, good. All right. Let me see here. Again, I just want to do a quick follow-up. I know that we were talking a lot before about states trying to plan the rollout of these measures and trying to think about the timing of all this. Somebody wants to know from a plan, will the timeline be written out somewhere? I think that's a really great suggestion. I don't know if we have that already available or it's something we should try and prepare. Erin, do you know if there's something quick we can make available?
Well, I do want to be, so the timeline that I've been speaking about is the timeline for the HEDIS measures, and that is going to be published in the HEDIS specifications, which will be coming out on September 12th. It lays out the measure reporting year and the measurement year and when things would be reported. We're expecting the measures should be reported at the same with all other HEDIS measures at the same submission time frame. We can certainly follow up. I don't think what's laid out in there is exactly this timeline for the following year, which is the year where we hope that they would be publicly reported. So I'm not sure, Deborah, if we have ways to follow up with everyone on this, but we can certainly follow up with that timeline written out more clearly.
Yeah, that'd be great. Yeah, because there was another question that came in. Please confirm that HEDIS measurement. It starts in 2018, reporting in 2019, starting. So there's a little bit of confusion, and I confess that even when I look at sometimes the HEDIS measures, I have to remind myself to which year they're referring, and in some cases it depends on the reporting period for a specific measure. So maybe we can. Have a little at a glance kind of a document that shows how the measures, at least the HEDIS measures and maybe some of these other things relate to reporting versus a measurement year versus so on and so forth. Great.
And another thing, Deborah, we could say is that if CMS, if this all works, we could potentially put this in an FAQ at a future point too.
Excellent.
Great.
Okay. Good. We've got about 10 more minutes. There's still some questions here. Let's see. Let me take this question from another plan. Thank you. If the discharge from an inpatient facility, this is on MLTSS, I'm sorry, this is the reassessment and care plan update after an inpatient discharge. If this discharge occurs and the member has not had a change in condition or needs, is a new comprehensive assessment and care plan really required?
It's an excellent question, and I think that what when we worked with our experts on this measure, the main input we got was that you don't know if there's a change in need until you do an assessment with the member. So until you've been able to see the member and understand whether or not that for the whatever caused the hospitalization has led to some change in the need for any services, any additional services, maybe some services discontinued, you really have to do that assessment. And then there needs to be an update to the care plan. It could be that the care plan is then just put back. It's exactly the same care plan, and that's fine. We're not looking for changes to it. But I think the overall input we got is that you don't know if there's been a change unless you do an assessment.
Right. Okay, good. Here's an important question, and it has to do with really are these measures going to be comparable from state to state? It's something that we struggled with many times over the course of trying to develop and test these measures. As you all know, there are many, many differences across states in how they determine eligibility for LTSS, whether those members who are enrolled in MLTSS plans always have to be at nursing level care or maybe not at that level of care, so on and so forth. So there are a lot of differences across states in how their MLTSS programs are structured and designed. This question really gets to that. Somebody asked how the quality of these care plans can be accurately assessed when the Medicaid benefit package may vary so much from state to state. In other words, plans may be doing their darn best in collaboration with their care managers to make sure that all of the patient or the beneficiary's needs are covered somehow in the care plan, but the services themselves may not be covered by the plan or even under the state's Medicaid benefits. That is a tough question. When I think back on some of the conversations that we had with our technical expert panel members and with CMS, I think we all acknowledge that there are going to be some limits to really being able to use these measures to make crystal clear comparisons across states. Certainly, we think that they are going to be very useful to individual state Medicaid agencies in comparing the performance of the plans with which they contract in that state. Whether they can do direct comparisons with those with plan performance in other states, we're trying. We've really tried very hard. Why? Because certainly CMS is very interested in comparing this. Some states that contract with health plans that operate nationally would like to know the performance of that same health plan in the neighboring state. So we really tried to do as much as we can to structure these measures so that there is the ability to fairly compare these performance measures of plans across states. But there's always going to be those kinds of limits that make it imperfect. Erin, do you have any other comments? I know we've struggled many times with this question.
Yeah, I think this is something that is going to be a learning experience for all of us as we move towards trying to have more national benchmarks, and it's going to be something that, especially as these measures are implemented in HEDIS and reported out, and we do our continual maintenance and review of them, we're going to be keeping a close eye on and definitely seeking input on trying to make these, as all of our other Medicaid measures are, comparable across states that have different benefit packages. Right.
We've done our best. A couple more questions. We've just got a few more minutes. Really quickly, I'm going to read them and respond very quickly. Erin, jump in if you have any other comments. One of the questions concerns, I believe, the reassessment and care plan after an inpatient discharge. If a plan has access to fee-for-service Medicare data, presumably for those members who are fee-for-service Medicare, not enrolled in a Medicare Advantage plan, can it use that data for the fourth measure? Or are fee-for-service Medicare beneficiaries excluded from the denominator? I believe the answer is yes. In fact, I know that New York State Department of Health actually is trying to construct some other measures using the data that it has access to, the Medicare data it has access to, for those MLTC plans to construct other kinds of measures. So I think if a state like New York is doing that because it has access and the capacity to analyze that Medicare data and link it to the MLTSS members, then if a plan has access to that fee-for-service Medicare data for its MLTSS members, then it probably is sufficient. Erin, does that sound right to you?
I think states can define this as they would like for reporting. So for a state that has this access, that's definitely something they could say is that plans that have access to the fee-for-service Medicare data, they can report it for those members who they have that are fee-for-service Medicare that they have it for. They may not want to also, though, then exclude, for example, if someone is in an MLTSS plan and also in a Medicare Advantage plan, that's a different plan, and the plan doesn't have access to the Medicare Advantage data, you might want to exclude those members. So states can probably take these and make them fit into their state. For HEDIS, we have to set one standard across every state to allow a level playing field. And so even if plans do, or some states have this ability to access fee-for-service Medicare data, because it's not consistent across all the states yet, we are not going to be including those plans in the reporting of the fourth measure at this stage.
Okay, final set of questions really quickly. Reporting is for CMS? No, the reporting is for states. So it really, if it was reporting for NCQA's HEDIS, if a plan is reporting to HEDIS, it would be to NCQA, or if a state decides, apart from HEDIS, to require its plans to report on these measures, it would be to the state Medicaid agency. Let me see. And just as a last reminder, the technical specifications are included as one of the resources on this webinar and will be available on Medicaid.gov. They are currently available on Medicaid.gov. We will be making the slides with all the links available on that same Medicaid.gov site. And then the final question is, we'll be sharing the list of questions and answers from today's session. Well, I know we've recorded this. We'll try to do our best to write up some of these questions and answers in a frequently asked questions document. So lots of these questions have been very helpful when we try and think about what those frequently asked questions are. We have reached time. I want to thank all of our speakers, Erin, Dan, Krista. Thanks so much to CMS for its support. We encourage you to submit your questions because we know that this is just the start of the proverbial journey. So again, thank you for your participation in today's call. Bryce, could you please close us out?
Thank you. This concludes the webcast for today. Have a great afternoon, everyone.